Afternoon and welcome to the American Diabetes Association's live webinar entitled CGM Coverage Criteria Changes in Medicare, What You Need to Know. My name is Laura Friedman, and I am the Vice President of Regulatory Affairs at the American Diabetes Association. Today, we'll be discussing the new Medicare coverage changes for continuous glucose monitors, better known as CGM devices. These changes recently went into effect on April 16th for people with diabetes on Medicare. The ADA believes that every person with diabetes has the right to the latest medical advances. Medical technologies like continuous glucose monitors, insulin pumps, and artificial pancreases can be instrumental in treating and managing diabetes. The ADA also leads the Technology Access Project, which is a coalition of patient and clinician health organizations, health policy advocates, and aligned medical device innovators. TAP has a goal of expanding access to technologies and innovations through state and federal policy change to help facilitate better management of diabetes, improve diabetes outcomes, and to allow people with diabetes to thrive. Access to CGM technology is extremely important given its clear benefits, especially for those communities experiencing an outsized impact of diabetes. Studies have shown that access to health insurance is the strongest predictor of whether adults with diabetes are likely to receive high-quality diabetes care. Compared with insured adults with diabetes, the uninsured have 60% fewer office visits with a physician, are prescribed 52% fewer medications, and have 168% more emergency department visits. Not surprisingly, as the data show, access to health insurance is also a strong predictor of whether people with diabetes can get the CGM as well. We are very lucky today to have two esteemed experts on our panel who will be able to share important information with you about how to access the CGM device, whether it's for yourself, a family member, or if you're a healthcare provider, how to help your patients gain access to these important devices. I'd like to introduce Dr. Robert Gabbay, Chief Scientific and Medical Officer for the American Diabetes Association, as well as Dr. Mahmoud Kazemi, the Chief Medical Officer from Abbott Diabetes Care. Since we only have 30 minutes, I'll start by asking Dr. Gabbay to share with everybody what are the main changes that the Centers for Medicare and Medicaid Services recently made for people with diabetes on Medicare to be able to receive a CGM.
Yeah, thanks, Laura, and excited to share really this victory for the diabetes community that we've been fighting for some time. So really, there are three changes to know. The first, in terms of coverage for CGM for Medicare, is really anyone that is treated with insulin, and that means regardless of the number of injections per day. It used to be that you had to document the injections and all of that kind of stuff. If you're on insulin, you're already eligible to be covered for CGM. So that's number one. The second change is, even if you're not on insulin, but you've had problematic hypoglycemia, low blood glucose levels, if you've had that happen, whether you're on insulin or not, and have diabetes, that's also a criteria. And so who might those people be? There's a group of medications called sulfonylureas. You may know them as glyburide, glipizide, glimepiride, glucotrol, Amaryl, any of those kinds of medicines. They're not insulin, but they can cause low blood glucose. And so if you've had problematic hypoglycemia, that's the number two criteria. So any of these work. And then the other change in terms of coverage, so it used to be that within 6 months of starting on a CGM, you had to go see your healthcare professional, and it had to be an in-person visit. And we've all learned that, it's that we can do so much by telehealth, by telemedicine. And so a virtual visit counts. So it can either be in person or virtual. So those are the three things. Any use of insulin, problematic hypoglycemia, and you can do that visit within the first 6 months virtually.
Great, thanks, Dr. Gabe. If anyone watching is interested in learning more about the specific criteria needed to access a CGM in the Medicare program, we have placed 2 web links in the event description for you. One is to the ADA CGM webpage that has a wealth of information on CGM devices and frequently asked questions, etc. And the other is a link to Medicare.gov that details the specific new CGM coverage criteria that became available on April 16th. So Dr. Kazemi, can you talk a little bit about how a continuous glucose monitor works in general and some of the benefits it provides to people with diabetes?
Absolutely, Laura. And thanks for organizing this very important telemeeting so that we can all share this awareness of this new update on the Medicare coverage guidelines. To begin with, continuous glucose monitors are devices that people living with diabetes can use to get their glucose values without having to do finger sticks, which, as we all know, have been a major barrier to people obtaining glucose information. The continuous glucose monitor basically allows a sensor to communicate with either your phone or reader, and it relays the glucose information to that device so that individuals can have access to their glucose levels and can see the trends and patterns in those levels, which allows them to make better treatment decisions when it comes to medications, when it comes to food choices and activity choices. And we know that continuous glucose monitors are very helpful in improving outcomes in people living with diabetes. They help reduce low glucose levels. They help improve overall glycemic control. And the impact of these recent changes on the Medicare side can really not be underestimated, because we already know that about 11 million people in the US are age 65 and above and live with diabetes. And of those, about 2 million have either type 1 or type 2 diabetes and are eligible now for CGM coverage under these new criteria. So it's really important that we raise awareness of this and help get these devices and this technology in the hands of those people who can benefit from it. So we really hope that CGM devices, including our Abbott Freestyle Libre family of products, can help people living with diabetes continue to improve their glucose control, which we already have evidence to back up, and which we hope will only continue to expand use in these groups.
Thank you, Doctor. Dr. Gabe, from your experience as a clinician treating people with diabetes, can you share your thoughts on what having a CGM might mean for older Americans who really never used any form of diabetes technology in the past?
Laura, literally it's a game changer, and for those that have not used this technology, imagine trying to tell somebody, you want to know what somebody's day looks like, and they send you 3 photographs during the course of the day. Well, that may not tell the whole story compared to a video that shows the entire day. That's the difference. Doing 3 or 4 finger sticks just gives you little point moments, but you don't know what's happening in between. And with a continuous glucose monitor, you know what the glucose levels are all the time. And so it's such a big difference. I can tell you, patient that comes to mind, 70-year-old guy that came in with his wife. He's sort of looking down, not making eye contact, has a Red Sox cap on. I'm here in Boston, and so the Red Sox are a big deal here. He starts saying, my glucose levels are all over the place. I have I'm on insulin. I don't know what to do, and it's really frustrating. And then his wife sort of jumps in and says, that the other day she had to call the ambulance to come because he was incoherent because his blood glucose levels were so low, and it was super scary for them. And one could imagine. And we talked about what a continuous glucose monitor was, how he could see what his numbers are, how his wife, if he allowed her, could also see what the levels are, and they can make sure that he doesn't get into that low dangerous range. So we got him a continuous glucose monitor. He came back a couple of months later. He was all smiles. He was making eye contact. His wife hugged me. I mean, it was like it changed their life. And that's what we see. These technologies have just revolutionized care for diabetes in so many ways.
Thanks, Dr. Gabe. As someone myself living with type 1 diabetes, I think there is no greater technology than a CGM. I love that description of the 3 snapshots throughout the day. I oftentimes say that it's like driving a car without a speedometer. You're just sort of like, I think this is where I'm starting. And then somehow you're on the highway and you're completely, it doesn't add up. So I really like that way that you described it. Dr. Kazemi, as a physician as well, you're aware that most providers check their patients' blood glucose levels every 3 to 6 months through a blood test called a hemoglobin A1C, which provides a 90-day average of a person's blood glucose level. But for many providers whose patients are using a CGM, they may also be tracking their patients' time in range. Can you speak with us a little bit more about what time in range is and its importance to health outcomes for people with diabetes?
Sure, I'd be happy to. So time in range is the percentage of time that someone is spending in a particular glucose range. And CGM devices that we've been discussing will actually automatically calculate that for the individual living with diabetes who's using the device. So usually there are different criteria that are used that have been already published in consensus guidelines around what percentage of time we would target for people living with diabetes to have in these certain ranges. And as you can imagine, there's a target for the time in range, but there's also a target for time below range and time above range. And the really important thing with CGM devices is that they provide the complete picture, as Dr. Gabe was mentioning earlier. You don't just see the average the way that hemoglobin A1C provides, you see the whole series of ups and downs, and we know that people living with diabetes go through those, and sometimes they're not even aware of them. And the CGM devices really do capture that and then provide the information and the concept of how much time is being spent in range, how much time below, how much time above. And then the patient and the provider can work together really to help figure out what medication changes are necessary or what other types of behavioral changes could help with improving the time in range. And we know that more time spent in range reduces the risk for complications down the road. So the target there is to really help improve the time in range and to reduce the time below range, because we also know that hypoglycemia or low glucose is certainly very dangerous immediately and needs to be avoided. And this is really an important aspect of this, again, Medicare coverage decision, because especially as for older individuals, they may not be as sensitive to low glucose and may not even be aware that they're going into that range. And CGM devices can help capture that and take the necessary actions to help avoid it.
Thanks. Dr. Gabe, do you have anything to add on time and range and its importance? Obviously, for years, it has been the A1C has been kind of the, important test to check. And I absolutely still get mine tested every, 3 months or so. But I just wanted you to have an opportunity to share a little bit more about time and range.
Sure. Thanks, Laura. A1C is this great average over 3 months, but it doesn't really help to make adjustments in therapy so much. You just know on average somebody is high, their A1C is high, and as a clinician, I want to know when, what would I adjust, and that information is not there. The other thing, if you think about an average, right, you can have your glucoses vary that much and have the same average as when your glucoses go like that. The average is the same, but boy, people don't want their glucoses to be all over the place. And the A1C doesn't give you that information. Time in range does.
Right, that ping pong effect. I remember
yes.
steering me clear of.
With lots of lows and highs, people feel terrible. It's, right. And you wouldn't know that from the A1C.
Sure. Great, thank you. Dr. Kazemi, then the new criteria, and you sort of started on this in your previous comment, but the new criteria also allows individuals who have a history of problematic hypoglycemia to access a CGM device. And Dr. Gabe also mentioned his patient in Boston, how it's helped him. How will this help, patients with their care management?
Yes, so I think that that particular coverage criteria for problematic hypoglycemia, as they put it, is an important one because, as Dr. Gabe had mentioned earlier when he went over the coverage criteria, there can be individuals who are not using insulin, who are using oral medications to manage their diabetes, who may in fact be having low glucose values and not even being aware of it. So that asymptomatic hypoglycemia, or having glucose that's in the low range without even having symptoms that you might be aware of, is particularly more common as individuals get older. So that's why we really welcome this change to the Medicare coverage criteria. Using a CGM device in that context can help people, first of all, become aware that they're even having these low glucose values, both the patient and their provider, and also then be able to make changes, not only when it comes to medication, but as I mentioned earlier, also behavioral changes around food choices, activity, etc. And that's, I think, the real beauty of CGM devices, is that, yes, they can be very helpful in adjusting medication, but they provide such a complete picture of the glucose profile that we can actually take other steps that oftentimes individuals living with diabetes begin implementing on their own without even a provider asking them to do so. When they see the impact of various foods and activities, that really empowers them to make the changes that are necessary to help bring their glucose values into that target range and to help lead much more healthier and in lives that are basically much less prone to complications related to diabetes.
Great, thank you. From a policy making perspective, I think we're at a really interesting point. The ADA has been working. The ADA has been working not only federally to ensure that there's access in the Medicare program for CGM devices, but also at the state levels through the Medicaid programs. I know there have been a lot of questions from advocates and policymakers who are in attendance today about what state policymakers can do to ensure that there is adequate coverage for CGMs in their state. And one thing we've learned from our work in the states is that coverage is pretty disparate throughout the states. And that one thing that we're encouraging policymakers to do is to take a close look at coverage requirements in their states and state Medicaid programs, and to make efforts to really align them with the changes that have been made in the Medicare program. But for many people with diabetes who stand to benefit most from some of these innovative technologies that we've discussed today, access still really remains financially out of reach for many. Much like other medical advances, diabetes technology is frequently unavailable to those who live in less affluent zip codes. So this includes large numbers of minority individuals who comprise really the lion's share of low-income Americans. Black and Latinx young adults living with type 1 diabetes, for example, are significantly less likely than their white peers to be able to get diabetes management technologies. Access to CGM technology is extremely important, as you both discussed with us today, given its clear benefits for those communities experiencing an outsized impact of diabetes. The ADA recently commissioned a study on the relationship between insurance coverage, age, geography, and race to identify where the greatest barriers to CGM access are. And the data shows that people who are least likely to get a CGM are people of color, low-income individuals who rely on Medicaid, and people who live in states with some of the highest rates of diabetes. In this study, we do find that poorer, older, Black and Brown Americans are the least likely group to get CGMs. In particular, 3 troubling trends emerged from the new data. First, individuals covered by Medicaid are the least likely to get a CGM, especially if they're a person of color. Where people with diabetes live is a major factor in how likely they are to get a CGM. And then young people are more likely to get CGMs than older Americans with diabetes. And now we have very high hopes that with some of these new changes in Medicare, some of these gaps may be closing. However, we really do remain focused on working with state Medicaid programs to increase this access. We could obviously discuss this topic for a lot longer. And I wish we had more than 30 minutes to do so, but I want to thank Drs. Gabe and Kazemi for joining me today, and to thank you, our audience. We really appreciate your time today and for your excellent questions. If we did not get to your question, we will do our best to respond in the next day or so. If you'd like to learn more about the newly implemented coverage changes for a CGM device in Medicare, as I said earlier, please visit the links in today's event description. And also, most importantly, if you think that using a CGM might be right for you or your family member, please make sure to discuss this with your healthcare provider to ensure that it's the right tool for the management of your diet.